Good afternoon. Welcome to a masterclass in framing to connect with hearts and minds. My name's Helen Bevan, and I'm from the NHS Institute for Innovation and Improvement in England. And I'm going to be joined on stage shortly for the second half of this masterclass by my colleague Maxine, who is a national leader in patient safety with the Department of Health in England. So in a sense, I get the first half to talk about some of the key principles and ideas behind framing. And then Maxine is going to join me for the second half to give us a very practical example. The reason why Maxine is staying down here to start with is because we're actually going to do some audience participation at some point, and we're going to select an elite band of people who are sat near the front to do some brainstorming with us. So be very afraid. So let's talk about framing. And you know what I'd say? Houston, we have a problem. This is some research that was conducted a couple of years ago by Scott Keller and Carolyn Aiken. And they're researchers from McKinsey, so this has to be right. And what they basically found was that what leaders care about and typically base at least 80% of their message to others on does not tap into roughly 80% of the primary motivation of the workforce to put extra energy into the change programme. And over the past few days of this forum, there's been a lot of talk about waste and how, as a community of improvement leaders, we have to reduce waste. Well, I would say one of the biggest wastes that we face is around change programmes and improvement quality safety programmes that fail to achieve their objectives. It's a hell of a waste. You know, we put so much energy in and we don't get the results that we need. And I would further say that it goes wrong at the beginning. It goes wrong in the way that we frame our change proposition. So let's talk about framing. And you know, many of the ideas that I want to present to you and that Maxine will exemplify, I think, this afternoon, come from social movement thinking. Because when you think about leaders of social movements, you know, community organisers, the great civic, community, faith-based mobilisation efforts, what those leaders were able to do was in a situation where they had no power, they had no resources, they were able to frame their calls, you know, to frame the challenge that was being faced in a way that mobilised hundreds of thousands of people and righted terrible wrongs. And you know, we can learn greatly as a community of improvement leaders from those movement leaders. So let's take a couple of definitions of framing from the social movement literature. So the first one from Snow and Benford is that framing is a process by which social movements and mobilising organisations, and to this I would add quality improvement leaders, construct, articulate and put across their message in a powerful and compelling way in order to win people to their calls and call them to action. So, you know, when we think about the programmes and the projects and the strategies that we work in, okay, how can we frame our calls? You know, how can we win people in a way that is powerful and compelling and calls them to action? And the second definition, which comes from McAdam, you know, framing is the conscious strategic efforts by groups of people, okay, to fashion a shared understanding of the world and themselves that legitimises and motivates collective action. So the thing about framing isn't just to make people feel good, it's actually about getting people to take action and to get involved. And the thing about framing, as McAdam says, is that it's conscious, it's deliberate. We stand back and we think about how are we framing our improvement efforts to get people on board. Now, let's do a little bit of the underpinning theory. You know, what we can learn greatly from social movement leaders is that if we want to get people to take action, in a sense we want to mobilise people for change, okay, the most effective way of doing that is through emotions. And we get to emotions, if you like, we make the emotional connection that motivates people to take action through values. So what that's telling us is that in terms of how we frame our message for improvement, we've got to be able to make a connection, connect with values, because that's our way into emotions. The thing about emotions is that they're not all equal. And there are some emotions that motivate action. So in our framing, we want to frame in a way that motivates action because we want to overcome the emotions that people feel that inhibit them from taking action. So, what are some of the clues, if you like, from social movement thinking about how we need to frame our change proposition? First of all, we need to build a profound sense of urgency. This situation that we face is so intolerable that if we don't take action now, people will die, people will be harmed, people will have an appalling experience. Because urgency overcomes inertia, and inertia is, standing back and not acting. So how much urgency, profound urgency, are you building into your framing of your improvement work? Anger. When I see things that are happening in my system, in the National Health Service in England, when I see how people are being harmed, when I see the inequity of care, that makes me very angry. And, and we need to build on that anger that we feel, because it will overcome apathy. We need to be hopeful. In a sense, what we have to do, the way that we should frame our message is around a different future. Okay? This is the kind of hopeful future that we are trying to build through this work. Okay? And often, when we're framing, we'll describe heaven and we'll describe hell. So heaven is, if we were to implement our safety programme across the whole of our community services, what would it mean? What would it look like? And in a sense, what's the hell? What would happen if we don't take urgent action now? And the thing about hope is that it overcomes fear. And certainly in our system in England at the moment, where so many changes are happening, people are very, very fearful. And again, we know that fear is an appalling waste because it inhibits people, it stops people taking action, it stops people seeing other possibilities. Through our framing, we want to build solidarity, okay? A sense, and again, we'll come back to this, Maxine and I, time and time again, that we want to build a sense of us. This isn't just me in a hopeless situation trying to do my little project. I'm part of a sense of us. And I think, for me, this has been one of the wonderful things about the past few days. Just what an incredible sense of us, of solidarity we have as a global improvement community. Okay? And however difficult things might be, we're not isolated. And related to that, a sense that every one of us can make a difference. You can make a difference. Okay? Every one of us can do our bit, which overcomes self-doubt. So think, around some of the ways that you're framing your message, you're framing your calls of improvement to build on those emotions that motivate action, to overcome those emotions that inhibit action. By the way, every slide that you're going to see in this session, both from Maxine and I, will be on the website for the forum, so you don't need to write these things down. Okay, so if we're going to build a compelling case, okay, what do we need to do? And I wanted to suggest 5 things that we need to do. The first thing we need to do is tell a story. Okay? We need to use narrative storytelling because, again, the evidence from those great leaders that were able to mobilize thousands of people was that actually storytelling is one of the most effective methods to connect with emotions through values. Because if I tell you my story, you connect with, well, hopefully some of my experiences and some of my values, and you say, wow, you're like me. Actually, I can connect with you. And we start from there. So it's really important that we make it personal. So the ability to tell our own story, okay, is key to framing. Okay? So, when I think of some of the work that I'm involved in at the moment around improvement for people with dementia, or for people who are at the end of life, for me to tell my stories, things that have happened in my family, why I personally feel called to take action in this area is so much more compelling. But it needs to be authentic. Because we have this idea of spin, or BS. I'm not going to say it on an international platform that's being recorded. People see through it. If it's not real, if it's just some la-di-da, wishy-washy promises that we don't believe in, forget it. This has to be authentic. We need to create a sense of us. Because if we're actually, wanting to mobilise people to our cause, what we're actually saying is that we share a set of common aims. We share a set of common goals, of common values that give us a platform to move forward. And the final thing is about a call to action is such a critical part of this, okay? In your framing for your improvement calls, it's really important that you're not just telling the story, or you're not just saying, this is the intolerable conditions that we're trying to overcome for this work. Actually, what you're doing is you're asking people to join you, okay? So, we have to build this in. And I think for me, since I've been working with a lot of social movement ideas, that one of the things that's different is that I've always believed in the power of storytelling and built it into what I do. But I guess what I've learned from the work that I've been able to do with community organisers and social movement leaders is just learn so much about that just telling a story isn't enough. We have to link the story to a call to action. We're telling the story because we want to call people to action. The two things come together. Another point that I think is really important about framing in healthcare improvement is that when we're framing and we're getting our message across, it's really important that we frame the future that we're trying to create as a step from the present. That if we actually say, join us to completely transform this hospital, and the picture that we're getting across, or the message, is so radically different, people can't cope with that. And I mean, this is a quote from Saul Alinsky. Rules for Radicals, I think, is one of the best textbooks ever for improvement leaders around how to mobilise for change. Okay? And he says, a new idea, okay, must be at least couched in the language of past ideas. Often it must at first be diluted with the vestiges of the past. Okay? People are much more likely to embrace change if it is framed as something that builds positively on what they are familiar with, than if it is something that seems far away and unachievable. So think about the direction that you want to take people in, and frame it as a step from the present. And again, there's some very, very interesting literature around transformational leadership. And again, what it's telling us is that paradoxically, those transformation efforts that were framed as a step from the present will tend to get better outcomes than those transformation efforts that are framed as we're trying to create a radically different future. So I thought I would tell you my story that's connected to this point. And last year, I had my 50th birthday. And for a woman, being 50 is a big deal, because it's like middle age, slow down. So I thought, I need to do something very symbolic, okay, that will be a big effort for me to show myself that there's life in this old girl. So I thought it needs to be something, big. So I thought, what I'll do is I'll run a marathon in the Arctic, okay? So I thought, picked this marathon, the Polar Circle Marathon, 100 kilometres north of the Arctic Circle, one of the toughest marathons in the world. And I had 6 months to train for this. And the thing is, I have a very busy life. So I hadn't done any exercise for 3 years, okay? No running, no gym, no swimming, just a mad life. So I had 6 months I entered the Polar Circle Marathon, and I had 6 months to train. So there's me. And that's at the starting line, and it was 25 degrees below freezing. And I was about to do the first 8 kilometres, which was to climb the polar ice cap. Anyway, so I had a running coach, and what was interesting was that very often I would get demoralised with my running coach, because he'd say to me, Helen, you've only been running for 2 hours, okay, and already you're 2 minutes a mile slower than you need to be when you run for 7 hours. And like, for me, when he said that to me, I just wanted to stop and go home, because it just felt to me the gap between my performance then as a runner and where I needed to be, to do my Arctic Marathon was so big. Every time he said things like that to me, he meant well, but it just made me feel demoralised and made me think, I'm an idiot for doing this, okay? But sometimes he would say to me, Helen, you've done really well. You're 7 minutes faster than you were last week. And that made me feel great. It made me feel like an Olympic champion. Because what he was doing then was framing the situation as a progression from the present. And in a sense, that motivated me. So, I could really see this point, that in a sense, I had a very big gap between where I was and where I needed to be able to run this marathon comfortably and safely. And if my trainer, if you like, said things to me that meant that I could progress from now, I was happy. If he said things to me that just felt too far away, I was unhappy. But I completed the marathon in 6 hours and 24 minutes, and I was very happy. So we said, in framing, we have to create a sense of us. To build momentum. So what I want to show you now is a framework for thinking about us. And this framework comes from social network theory. And this is something that all of us need to think about. When we're framing our improvement method, are we thinking about strong ties or are we thinking about weak ties? Okay? More will be revealed. So, what I would say is, like, when I look certainly across England, and I think in other countries as well, most of the improvement effort that I see focuses on strong ties. Okay? Our method, our mindset, our theory of change is based on strong ties. So what does that mean? A strong tie, I have a strong tie with somebody who has similar values to me, similar life experiences, similar goals. Okay? So, strong ties are people like us. When we interact with people like us, and when we have a strong ties model of change, it's a peer-to-peer model, which means, we have this idea, that change will be much better if we spread it peer-to-peer. So GP to GP, nurse to nurse, gynecologist to gynecologist. And sometimes people would say, because I'm a social scientist, and people would say to me, Helen, you're a social scientist. You cannot influence GPs to change, because only the best way to influence a GP is through another GP. So find a GP who is a champion, you influence them, and then you have to leave it to them to influence all the other GPs, okay? Because, the theory, influence is spread through people who are strongly connected to each other. And what we also know is that when people like and trust each other, they are more likely to be influenced by those people, and change is going to happen. And it works because people are far more likely to be influenced to adopt new behaviours or new ways of working from those with whom they are most strongly tied. Okay? So that tends to be our model in healthcare improvement. Now, we're going to do something interesting. So, we are going to have a little group. So Maxine's joining me. So Maxine, who would you like to have as your brainstorming group? Oh, so let's all give a round of applause for this wonderful group of people here. If we can have the lights up. So you're all happy? Yeah? Good? Yeah. Okay, so what we're going to do now with this group is we're going to have a brainstorm, okay? Let's think about strong ties. So what are the advantages of strong ties, a strong tie approach to improvement, and what are the disadvantages? What we want you to do is, in this little group here, the mics, if we can turn the mics on, please. Are the microphones on? Yeah, great. Okay, now the thing about this, nobody is going to be socially humiliated, okay, by the wrong answer. It's a brainstorm, which means, you know, we appreciate everything that you say. Okay, so let's start off by thinking, if you were going to have an approach to spreading improvement, spreading quality improvement that's based on strong ties, what are some of the advantages of working in that way, peer-to-peer? Why is it a good... Great, we have one here.
Same language.
Same language, fantastic, yeah. Any more?
Same values.
Same values, exactly.
Perception of similar interest.
Yeah, very good. Oh, good group here. Well chosen, Maxine.
I know.
Yeah.
Purely random.
Yeah. Can't be. Ooh. Okay, any more?
Trust.
Yeah, absolutely. People that trust each other are much more likely to be influenced by each other to change. Any more?
Learn from mistakes.
Yeah, and in a sense, people will learn from mistakes because, in a sense, the other people that have made mistakes, we actually trust those people and we're willing to listen to them. Yeah?
Underpinning structures.
Yeah, fantastic. So, in a sense, the underpinning structures already exist. So, in a sense, the clinical networks and professional associations already exist that we can do this spread through. So, great point. Yeah. I have two more.
They would have perceived the same difficulties.
Yeah, great. Perceive same difficulties.
Nearly everyone's spoken, Helen, in my group.
Have they? Who'd like to give another one? Got
Anyone from this side?
Yeah. Anybody down here want to give us a point? Why is it good to work through strong ties? Yeah, I've got one here behind you.
Sorry?
Yeah, great.
Just physical proximity?
Yeah, often. Yeah. Okay, so what are some of the disadvantages of spreading quality improvement through a strong tie strategy?
Should we have a new group?
Yeah, yeah.
Be fruitful.
Yeah.
Should we have this group here?
Very good. They look very intelligent.
They do, don't
Yeah.
they? Could you pass that mic along for me?
Okay, so this excellent new group, okay, we've had a very high standard set by this group, so we have to keep it up. Okay, so what would be the disadvantages of strong tie strategy?
It imposes boundaries.
Exactly. Very good.
This group is self-motivated. They're passing the mic themselves.
Oh, they're great. Oh, I love it.
Isn't it great? Preaching the convinced?
Yeah. Okay, that's very good. So in a sense, we're preaching to those already convinced, and in a sense, because we tend to think the same. Yeah. Very good. Okay, next one.
Sense of competition and rivalry.
Yeah, that there's actually, because people are kind of similar, often there's competition that is getting in the way. Very good.
Mindset that lacks controversy.
Very good. And you know, so mindset that lacks controversy, that's a really, really important point. Maybe I'd frame it the other way around, which is to say that actually if we want to innovate and we want to get ideas across broadly, that in a sense, because you've got strong ties, you end up with groupthink. So in a sense, everybody thinks the same already. You know, there aren't new ideas. Right.
This is probably related, but constraints stemming from hierarchical structures.
Yeah, very good.
Ooh, now then, could you pass this mic along?
Thank you.
It will not influence people outside the group.
Yeah, and another really important point, because when you have a strategy that's built on strong ties, it can only go so far. It can only go as far as the boundary of the group. And if, we're trying to create change at scale and pace, strong ties won't take us there. Okay, do you have any more? These are pretty good. Can I have one more?
Over there.
Oh, great.
Now, another challenge.
The physical challenge.
We can overcome.
Yeah.
No, it's not always easy to have openness with people that you have strong ties with.
Yeah. And in a sense, it's like openness to new ideas, openness to different perspectives. Great point. Very good. Okay, we have one more here. Yeah.
Only a limited group may benefit.
Fantastic, yeah.
Should we give them a round of applause, Helen?
Very good, yeah.
Thank you.
Yeah, very good. So, if we're going to sum this up, what we're basically saying is that, strong ties are really important. They have many advantages. And so we do need to work peer-to-peer because people will be influenced by people like them. But in a sense, a strong tie strategy, particularly, when we're trying to change whole organisations or work across boundaries of care, okay, it has its limitations. So, we need to both, work with the strength of a strong tie, but we need to understand the limitations. So the other way of thinking about ties is weak ties here, okay, and the column on the right there. And when we're talking about working through weak ties, what we mean is we're building bridges between groups and individuals who were previously separate. So how can we create a message that unites people, okay? And we're creating relationships based not on pre-existing similarities, as we have with our strong ties, but on common purpose and commitments that people make to each other to take action. So in a sense, it's about, when it comes to a weak tie, it's about having a common agenda, a common goal, and making commitments to us. And when we're working in a weak tie way, our aim is to mobilise all the resources that we potentially have, all the people that we wouldn't normally even think about in our organisation, our system, or our community. And what I'd say is that in the era that we are now of quality improvement, where we need to take things, we have to work with weak ties as well as strong ties. We need both. But just working through strong ties isn't enough. And there are some reasons for this. And you absolutely got these here. Weak ties, a weak tie strategy, connecting with people that are different to us, are much more likely to lead to change at scale because they enable us to access a lot more people with fewer boundaries. And, you talk about imposing boundaries here, won't influence outside. They were very intelligent answers. And what happens is that in situations of uncertainty, the kind of situations that we as an improvement community find ourselves in now, okay, where we're not sure where the budget's going to come from, we're not sure if we're going to be restructured, we're not even sure if there's going to be jobs for everybody next year. When we're uncertain, what we tend to do is to go right back into our strong tie relationships because it's comfortable, it's people like us, Yet, the evidence tells us very strongly that weak ties are much more important than strong ties when it comes to searching out resources in times of scarcity. And that's what we need to be doing now, searching out new resources, different ideas when things are tough and scarce. And we know the most breakthrough innovations will come when we tap into our weak ties. And again, some great, answers here about, that in a sense, strong ties mean that we don't challenge, we don't innovate, okay? And history, if we look back, okay, at the history of transformation and large-scale change, what it tells us, weak ties will probably give us the best chance to deliver large-scale improvement in a challenging timescale. So the message that Maxine and I want to get across today is that when we think about framing and framing to connect with hearts and minds, we need to frame not just for strong ties, but for weak ties as well. Now, what can we learn from those great social movement leaders who were able to change the world, okay, because they were able to mobilise at scale. The first thing that we learn about them is that they were brilliant at working with weak ties. And in a sense, they were brilliant at putting across messages that would appeal to a lot of different people. And if you look into the social movement literature, what it tells us is that there are typically, time and time again, when you look at the social movements that really did deliver significant change, that you see three components. You always see these three components almost every time of a great narrative or a story, or in a sense, in framing for weak ties, okay, you always see these three components. And the technical term for this is master framing. So if you go into the social movement literature and you look at master framing, you'll see this. And what we basically see are three things. First of all, we're framing our message diagnostically. So what's the problem that we're addressing? What are the specific source or sources? Who is the enemy that we are confronting through our quality improvement work? Okay. Secondly, is prognostic. We said about creating a sense of hope, of a different future. So what could the future look like? And what's our plan of attack? What are we going to do to carry out the plan? And the third aspect is motivational. And that is about, why is this urgent? We talked about urgency to overcome inertia. What is our call to action that connects with the motivational and emotional drivers of the audience? And, if you take nothing else from this session today, when you go back to your workplace, think about how are you framing your improvement method? Have you got a diagnostic component? Have you got a prognostic component? Have you got a motivational component? It's interesting to me because when I look at what's going on in England at the moment with our cost and quality challenge, what keeps happening time and time again is that we focus on the diagnostic, okay? Like we've got a £20 billion gap, okay? We focus nowhere near enough on the prognostic because as leaders, if we can't create a compelling sense of a different future in line with values, we won't take people with us. And often I think in improvement we just shy away from the motivational, and we have to embrace it. We have to embrace values and we have to embrace emotions. So, at this point, I would like to hand over to my esteemed colleague, Maxine Power. And Maxine is going to give us a wonderful case study that I really hope will bring us together around, the master framing, the three elements, and also strong ties and weak ties. So, Maxine.
Thank you, Helen. Thank you. So, before I start, I just need to share with you my experience of having worked with Helen, which is fantastic. So I consider myself to be a student of Helen's. Interestingly, though, she said to me about 3-4 months ago, I'm thinking of doing this session in Amsterdam. It's just, it's going to be a small sort of fringe meeting with about 30 people. Do you think you could use the safety story to sort of illustrate some points? So I said, that'd be great for me. We can have a little think and refine as we go. Anyway, about a week ago, I got a text saying, we've been moved to the large hall, 600. Have a glass of wine. So that's the context for this. So thank you, Helen. It's an absolute privilege. So I was somewhere about 1.5 years ago now, asked by Jim Easton, who some of you will have seen this morning in the plenary, to think about how we might organise for safety and safety improvement within the context of the Quality, Innovation and Productivity programme that Jim leads and Helen and I are part of. And I was absolutely delighted that safety was a really key feature. So sort of the genuine commitment to actually try to deliver through quality is right at the heart of the programme. I was also delighted because I'd been working with a whole host of individuals, some of whom you'll see on this schematic. So those of you from the UK will recognise the names, but for others, it really just is an illustration to say it was absolutely not a blank canvas. So we'd worked really hard in England to actually start to mobilise clinical teams, frontline staff, organisations to step up and really take safety improvement very, very seriously indeed. So it's a privilege to walk into a context like that. It's also quite challenging and quite daunting because you think, well, actually, what do we do different? So Helen and I sat down, we talked, and we thought about what we might actually do, and we convened a group who'd been involved in all this work, and we met in London over a 3-day period. And we talked about what we would want to accomplish together that was respectful of what we'd done in the past, but that had some different domains, different dimensions. So it was respectful of what we'd done, but it was innovative, and innovative in a particular way. The innovation was about moving together faster. So the pace was what we'd identified as being really quite cripplingly slow. So that was a challenge because what we didn't want to do was sacrifice the quality of the programme for the pace of change, which meant we had no choice really other than to look at some fairly disruptive innovations. So I'm going to show you something now which is a driver diagram that emerged out of that 3-day consultation and which has been refined since, but actually very little. And there are some key points, I think, to take from the driver diagram. One of them is actually the fact that what we were doing here was framing something very different in terms of the way we were describing the ambition. I'm going to talk a little bit more about that. But this whole notion we tested with clinicians of protecting our patients from harm shifted what we believe to be almost a negative focus on the outcome, so pressure ulcers, and moved it into we are protecting our patients together. It's an important thing. It was also one of the other things that became very important was that we realised at the time that we were counting the wrong things. So the unit of currency that we decided to use moving forward was the patient. And we said, well, out of all these magnificent programmes that we've had over the past 5 years, what are the things that we'd really like to deliver in the context of this mobilising effort? And there were 4 things that really came out, which is signalled here in this aim statement. And that was to look to deliver dramatic reductions in pressure ulcers, falls, catheter-acquired urinary tract infections, and venous thromboembolism. So that's the VTE. And everybody said, well, so what's the difference? And I said, the difference is, if this is me in a hospital bed, I don't want any of them. So protect me from pressure ulcers, absolutely, but not at the risk of me getting a catheter infection. I don't want any. So that's quite a dramatic mental shift, both for us in terms of thinking differently and in terms of actually making our measurements fit for the aim that we've actually got. And you'll see that we've committed one of the improvement sins in that aim statement by not having an ambitious numerical goal. And that was because at the time we had no idea how many patients actually did travel through our healthcare systems harm-free. And that was part of our initial bit of the journey, was to actually get that information so we could actually start to refine our aim statement. Now, the things that come after that are quite generic. I'm not going to focus on them right now because I'm going to take you into them through this framing process that Helen describes. Now, in terms of diagnostic framing, where's the outrage? What's the big challenge? We started to look and we started to get a sense of the numbers of patients that were affected by these issues in England alone. These are probably conservative estimates, and they are associated with harm. And many of you will be drawn to the picture in the bottom right-hand corner of the frame. So this gentleman is a 68-year-old gentleman who comes into hospital. He's already had an amputation, and he comes in with problems with his other leg and requires an amputation. He gets risk assessed for pressure ulcers on admission, and everything works well. He goes to theatre, he has a successful surgery, and the day after he comes out and he wants to go to the day room. The staff take him to the day room, and he sits on his cushion that he's been given prior to surgery, which is for somebody with moderate risk of pressure ulcer development. And 3 hours later, this is what it looked like. So the post-surgical reassessment hadn't happened. What's interesting is that actually we see those numbers when we feel that horror. The thing that struck me most when I learned about this gentleman was actually prior to his surgery, he lived in a residential home close to his sister and had been very, very active socially in the local pub. Post-surgery, he had to go into a nursing home away from his sister and without the support that he'd got from his social context. And he died some months later, weighing 4.5 stone. It's quite a sobering thought when you think that there's 50,000 of those potential impacts, not like that, but similar in England alone. So what are we going to do? Well, I think we come to this with a positive mindset, actually, that in England now, we're trying to get people to engage in a plan that says we can save lives, we can reduce harm, and we can save money. The things are compatible with one another. We want to focus on quality, and we want to focus on positive aspects of harm-free care. So we don't want our patients to have any of these things, and we will measure in that way. How will we plan? Well, Helen's done a very good job to demonstrate to everybody over the conference, and I don't want to preach to you about this, but mobilising is absolutely necessary but insufficient. So we need to mobilise at scale, but we need to organise as well. So we need to organise to understand how we're going to deliver the improvements we want to see. And from that, we can do none of those really unless we agree a measurement strategy that feels comfortable to the people who are looking at it, paying attention to it, and being reinforced by it. So planning was everything for what felt like a very long time, but I think has paid dividends. And strategy was important too. So who are the people that we're actually going to get to engage with us in this campaign to actually change the way we think about patient safety and harm from these 4 things? And we very much decided that actually the partners who'd helped us craft the programme were key in terms of helping us to mobilise. And we were very much thinking about connected campaigns in the way that we were moving forward. We knew we'd got regions, so we've got 10 geographical regions in England who were already stepping up to say, we would like to work with you on this. We need to understand it better and how it fits with what we're doing, but we really want to move forward. So we said, well, what would it look like if 10 organisations from each of the 10 regions brought 10 people to the table? And pretty quickly, you've got an N of 1,000 people engaged and stepping up to think differently about safety improvement. And that's exactly, for the first wave, the way that we have organised the work in the regions. We wanted to focus on outcomes, but as I said, these a different emphasis on outcomes. So not this individual, what we would class potentially as siloed thinking, but a compact of outcomes that we wanted to protect our patients from. And we really wanted to understand whether what we were doing was actually impacting on both healthcare professionals and patients in terms of the measures that we were seeing. The motivational framing, given the subject matter, I think is a gift, actually. It's something that I still feel like, I mean, when I hear Helen talk, I'm just totally blown away by the theoretical frameworks. And for me, I feel like I'm a delivery person who loves to understand what the theory is doing for my program and how I can improve it. And I think this is one of the ways that it's helped me to understand what I'm doing when I'm working with improvement teams. And what I've realised is actually that the motivational framing, I think we pay lip service to it, or I pay lip service to it. So I do it once, right at the beginning, so I know I've got to tell stories, I know that pictures are important, and I know that data about my patients and my ward and my organisation or my health system feels important. I don't think yet that I do it sufficiently at every opportunity. Because I think it's so powerful to just step back and restate, what are we doing here? Why are we here? The other thing, of course, is that with motivational framing, I think you really need to understand the audience that you're speaking to, because clearly, you know, some people like evidence, some people like pictures, some people like stories, and some people like numbers. And actually having that full repertoire is really, really important for me. And also, I think that as a community of people, we have to have a do once and share kind of mentality. So I'm really delighted to see that on the NHS Institute stand there's a box of DVDs that's just a box of patient stories, basically. And as part of the programme that we're developing in England, we're going to have a whole load of patient stories online, and there's a link here to one of our first patient stories. And it's been so powerful that within our sessions where we've been working together with the teams, the clinical teams, we've actually started a mini campaign within the programme that's called Stephen's Campaign. And what we've got is we've got each member of our group, so those 1,000 healthcare professionals, to actually commit to showing that film to 10 of their colleagues. And so very quickly, you start this cascade of commitment to something that is actually really important and that you can potentially never measure the impact of, because it really just becomes an escalating cycle of engagement, hopefully. So Helen told me when we were preparing this, it's not good enough just to do the framing. What is the commitment? What's the call to action? And she's absolutely right. And I think actually, thinking about it, making that conversion from the framing to the call to action feels like a step that I found quite difficult to do. So what are the specific things that people can take away from our work that will actually allow them to think that I can make a difference? Remember that I can make a difference thing. And I think we've developed this list. You've seen one on Helen's slides, you'll have seen one on Jim's slides this morning. So we're constantly thinking about what is our call to action here and how can it be improved, refined, used by others to actually get wider engagement. Because really this is about letting go, not about taking control, which is really hard for me. So Helen talked a bit about weak ties and strong ties, and asked if I would sort of give a little account, very short account, of how we've thought about weak and strong ties in the safety programme. So one of the ways that we've done this is in England we've had some fantastic work happening in hospitals. We've had some fantastic work happening in specialist areas, for example, in mental health and in community. What we struggled with is to get people to work across organisational boundaries. So in Safety Express, we've made the unit of work a community and said actually what we would like organisations to do is step forward to host on behalf of a team drawn from a community. Now, in some ways, this has been quite challenging because actually we brought them to the table with the term team loosely typed over, but actually they've spent quite a lot of time getting to know one another. And that's been really interesting, but massive benefit, not just for the issues we've got here, but for the health economy as a whole, when teams start to learn how to improve together for a community or a population. And I know some of your health systems structurally, that's much easier to do than it currently is in the English system. So we're nearly there. I think we also structured for weak ties in the programme design. So one of the things that has been really fascinating to the teams we've been working with is they've said, but there's no bundles. We like the XY bundle, or we like the ZZ bundle. And interestingly, what we said is, where's the common ground? What is the thing that you are all trying to do? And when they actually started to unpack it, there are several pillars of common ground against which this programme is designed. And this has been so countercultural you would not believe. So I go in to visit organisations, and round the table there'll be infection control, pressure ulcer management, falls people, the thrombosis committee, and some nursing staff. And they present to one another, because they present their 15 minutes of what we've done so far. And you can see them looking at one another thinking, oh, we're doing that? Oh, yeah, we're doing that. So what are you all trying to do? And actually, interestingly, somebody over here is doing hourly rounding for falls reduction. Somebody over here is doing hourly rounding for pressure ulcer prevention. And guess what? They look slightly different, and they're in the same organisation. So what is it that we can do to rationalise and make sense through developing the weak ties into something that actually gets us momentum? Salford Royal's a great case example for this. So if we think about hourly rounding, so the principle being that if we get to our patients very regularly, by doing the routine, we can stop the crises that Jim talked about. So Salford came forward and said, we have got an hourly rounding schedule that we've developed to reduce falls. And it works. It's clear, it's simple, it's measurable, it's been tested, it works brilliantly. What are we going to do with it if we then have an hourly rounding schedule for our forearms? So we thought about it. And actually, the transition from 1 to 4 harms, still doing the same thing, has been an interesting journey. Some organisations have made it, some have not. And this is still very fresh off the improvement circuit. So this is about thinking about integrating the questions so that actually we're preventing more than just a single issue happening for our patients. And they're beginning to develop tools and materials that actually support that. Now, you might be thinking, well, that's fine, but I work in mental health or I work in maternity. What's the relevance for me? And actually, what I would say to you is, what are your 4 harms? So critical care is a great example. We've worked on VAP, we've worked on line infection, we've worked on med errors. What about the patient? Does he want any of those things to happen? So I think we need to shift gear. It's been really, actually, totally enjoyable thinking about how to draw theory down into a really sort of difficult practical challenge. And like any person in this room, it is not something that I've done on my own. I've got a fantastic team and a fantastic advisory group who have stopped me falling into the pitfalls that are clearly evident in what I've just described to you. But I have learned something. I'm a technician. I love measurement and I love the technical tools of the trade. So I love statistical process control charts. I love all that stuff. But actually, I think I've had it wrong, because I do believe that actually most of the improvement I've seen has come through engaging with people's hearts and not their minds necessarily. I do still think we need some of that, but I think that weak ties can definitely be optimised through shared vision, through aims, through breaking silos for design benefit, and through working across team boundaries. Thank you.
So, thanks very much for that, Maxine. And I think you can really see, some of those principles coming across there. So, if we're going to frame, let's be clear who we are framing for. And let's understand that if we're going to work in a way where we want to broaden out our change process, we need to work through weak ties as well as strong ties. And that when we're framing our change proposition, we need to think about diagnostic, we need to think about prognostic, and we need to think about motivational. And we particularly need to think about motivational, as the diagram shows here, because actually, most of the change comes by our ability to connect with hearts. So I just wanted to show you a couple of things. The first thing I wanted to just show you is some of the work that both Maxine and I have been involved in is working across England with the nursing and midwifery community. And we've been using some of these framing and narrative principles to help our nursing and midwifery community to create their own call to action. And they have a call to action, which is to engage 200,000 nurses and midwives in taking action, into committing to specific actions around quality and cost improvement. And I know some of you have got some of the brochures already, but I've left a few down at the front and after the session if you'd like to see those. And just to I do like a nice quote, a nice motivational quote to end. So I've actually got you three. Okay, so this is the first one. This one comes from Gary Hamill from London Business School. And again, I think this is reinforcing the point that often as leaders of improvement we're saying, I cannot get those flipping doctors engaged in improvement. And, maybe we're thinking about this the wrong way when we talk about how do we engage people in improvement. Maybe actually we need to start from a different place and to look inside ourselves and think, how are we as leaders and improvement advisors getting the message across? To what end and to whose benefits are our employees being asked to give of themselves? Have we committed ourselves to a purpose that is truly deserving of their initiative, imagination and passion? And if we're not getting that across, then I think we're missing the first base. So let's, rather than looking out there and saying, well, people aren't getting engaged as if there's something wrong with the people, let's start from ourselves. The second one comes from Charles O'Reilly, Leaders in Difficult Times. And, and he talks about, as leaders, we are signal generators. And, the words and actions that we are using are constantly being scrutinised and interpreted, especially by other people that are below us in the hierarchy or in other places in the hierarchy. So every message that you're getting across, okay, everything you're framing, every time that each one of us overemphasises the diagnostic and doesn't focus on the motivational, people are picking it up. And in a sense, as leaders of improvement, again, coming back to this thing when we talked about weak ties, about uncertainty, okay, that weak ties are the most effective way to deliver change in times of uncertainty. Signal generators, that's us, reduce uncertainty and ambiguity about what is important and how to act. So, let's remember that all of us are signal generators every day in our interaction as leaders of improvement. And then the final quote, I think, is one that is really pertinent to being here this afternoon in Amsterdam. And, let's go back to when we talked earlier in this workshop about emotions that inhibit actions and how we use emotions that motivate action, to overcome those. And we talk about, a sense that every one of us can make a difference. If every one of us is called to action, we can make a profound difference for thousands of people. So I thought I'd end with a quote from Anne Frank from Diary of a Young Girl, 1945. How wonderful it is that nobody need wait a single moment before starting to improve the world. So one final thing I wanted to ask you. Will you join me? I'm going to call you to action now, okay? Will you join me in this quest, if you like, to deliver harm-free care, to significantly improve the quality of what we do? If you will join me, will you stand up? Fantastic. We have a movement. Thank you very much.